if you're a surgeon, you're going to learn a lot and improve your skills doing this very unique kind of training. And now with you, Dr. Anderson. I think Sasha is having a difficulty to start the video. Sasha? Just give us a couple of minutes, guys. Oh, very good. One more minute and we are going to start.
Well, good afternoon to you all, ladies and gentlemen. I hope you recognize this picture. We showed it to you last week when we introduced our topic, which is transposition. You will remember
Sasha, we are seeing your WhatsApp now. I think we have to start over.
I hope that it is the drawing made by Matthew Bailey, countryman of mine in 1796. This is the first illustration of which we are aware, showing the features of the lesion we are to discuss. And I pointed out that at the time, Matthew called it a singular anomaly. We discussed last week the controversy that has raged since then as how best we should describe this lesion. And what we settled on was that it would be better if we called the situation discordant ventricular arterial connections. But I know full well that you will all continue to describe it as transposition. We also discussed last week that what we are going to continue our discussions today relates to the combination of discordant ventricular arterial connections with concordant atrioventricular connections. In the 2 weeks prior to that, we discussed the combination of discordant ventricular arterial atrioventricular connections. And we mentioned how the two discordant connections canceled each other out so that we had congenitally corrected transposition. And we've also mentioned that you can have discordant ventricular arterial connections in the setting of isomeric atrial appendages. We then have mixed atrioventricular connections, but the problems relate to the abnormal venoatrial connections. And we've discussed that oftentimes you have discordant ventricular arterial connections when you have double inlet ventricle. Indeed, that is the most frequent combination in the setting of double inlet left ventricle. And we can also have discordant ventricular arterial connections when we have absence of one atrioventricular connection, particularly when we have tricuspid atresia. But today, as the default option for transposition, we're going to continue our discussions of the arrangement in which we have discordant atrioventricular connections combined with concordant atrioventricular connections. So these are the segmental combinations we're going to be looking at. In most instances, we have usual atrial arrangement. So the morphologically right atrium is where you expect it to be. The blood passes across a morphologically tricuspid valve into the right ventricle, and the ventricular mass is showing right-handed ventricular topology or a D-bulboventricular loop. So then we come to the problem, because rather than the morphologically right ventricle giving rise to the pulmonary trunk, as is usually the case, it gives rise to the aorta. And it is this combination that means that the blood goes round in parallel rather than in series. And that is the problem that confronts you all in the clinical situation. So the morphologically left atrium receives the blood from the lungs, passes it into the left-sided morphologically left ventricle through a mitral valve, but then returns the blood to the lungs because of the discordant ventricular arterial connections. So to emphasize again, the circulations are in parallel rather than in series. But we have to remember that although this is the arrangement we see most commonly, and it is the arrangement with usual atrial chambers, this is only the commonest variant, because we can have exactly the same situation when the atrial chambers are mirror imaged. So when we have mirror imaged atrial arrangement, the morphologically right atrium, of course, is now left-sided. But we have concordant atrioventricular connections. So because we have concordant atrioventricular connections, the morphologically right atrium is now connecting to the morphologically right ventricle, but the morphologically right ventricle is left-sided. So now we have left-handed ventricular topology. Because then we have the discordant ventricular arterial connections, the blood is again going round in parallel rather than in series. So on the other side of the heart, we have the right-sided morphologically left atrium pumping its blood into the right-sided morphologically left ventricle and returning the blood to the lungs. Now you'll remember that last week, Diane Spicer showed you examples of both of these lesions. It had been my intention to include those videos in today's presentation, but you're going to find out that we have rather a lot of hearts to look at today, particularly in the setting of ventricular septal defect. So those of you who wish to refresh your anatomy, refresh your understanding of the anatomy that we see with simple transposition, with intact septal structures, with usual atrial arrangement, you should return to last week's presentation. The heart we showed you with mirror imaged arrangement last week was rather complicated because it had an atrioventricular septal defect, but there was discordant ventricular arterial connections with pulmonary atresia. So again, those of you who wish to refresh your understanding of the arrangement with mirror imaged arrangement, look again at last week's presentations. Because today we're going to concentrate on the associated malformations. But we should not forget that even when we have simple transposition, we can have variation in the arterial relationships. And those variations do not disturb the segmental combinations. So when we consider the arrangement of the aorta relative to the pulmonary trunk, and remember that when we discussed this last week, we made the point that for a long time, people defined transposition on the basis of an anterior aorta. And it is indeed the case. Almost always the aorta is anterior. And in the majority of cases, it is right-sided. But when Diane shows you the hearts that have associated malformations today, she's going to show you an example where the aorta is more or less directly anterior. Interestingly, she's going to show you several examples in which, despite the fact that you have usual atrial arrangement, right-handed ventricular topology, the aortic root is to the left of the pulmonary trunk. And I'm going to emphasize that finding very shortly. And we should remember that no longer can we take an anterior aorta as the defining feature of transposition, because you can have discordant atrioventricular connections, discordant ventricular arterial connections with concordant atrioventricular connections when the aorta is posterior and to the right. And we are hoping that at the end of today's presentations, Adrian Cruchard is going to join us again from Birmingham, and he's going to show us one of these very rare combinations with what we now call posterior transposition. But the interesting ones are those with left-sided aorta. So this is a beautiful picture of this setting. There is the aorta. We know it's the aorta because it's giving rise to the coronary artery. The picture is taken in the operating room by my late lamented colleague, Benson Wilcox. And there's no question, but in this heart, the aorta, which is arising from the morphologically right atrium, is left-sided relative to the pulmonary trunk. The ventricular mass is showing right-handed ventricular topology, and there was
Sorry, guys, we're going to fix that. Just one more second. Sorry, guys. Guys, I think Sasha lost his internet connection. I'm so sorry. Can you wait a little bit more? I think he's trying to reconnect. Just one more second, guys. We're going to restart. Adrian, in this meanwhile, do you think you can show the specimens that you have?
Yes, if we want that, sure.
I think so, yeah. I think it's amazing. While Sasha tried to reconnect.
Okay, so you can hear me well, I hope.
Yes, very well, thank you.
Okay, I will start with the first heart. And the reason I want to start with this heart is because we have a lung and heart block. We discussed a lot about the position, the interrelationship.
Full screen, Adrian, full screen, please.
Yeah.
This is full screen. He's doing right. The only thing, Dr. Silverman, if you want to change it, you go to view on the right upper corner of your Zoom, and then you click on view. You click on speaker view. Then you're going to see only his screen. If you are on gallery view, you're going to see all of the panelists, and then it's going to be small. But if you go to speaker view,
all done.
Very, very good.
Okay. So the reason I wanted to start with this heart is because we have the lungs and the heart block. Otherwise, I find it very difficult to indeed define very well where exactly is the aorta in relationship with the pulmonary trunk. But in this heart, because you also have the pedicle, the esophageal and tracheal pedicle, we can definitely see that the aorta comes from this anterior ventricle and the pulmonary trunk is located here, posterior and to the right of the aorta. Now, this is a morphologic right atrium located on the right side of the septum, whereas here there is a morphologic left atrium located on the left side of the septum. So it's a usual atrial arrangement. This morphologic right atrium will connect with a morphologic right ventricle that you can see here. And you'll notice here that there is a defect in the interventricular septum. But this is a trabeculated ventricle. It clearly looks like a right ventricle. Whereas on the other side, the morphologic left atrium connects with the morphologic left ventricle. As you see, the trabeculations are fine and crisscrossed. When we look at the ventricular arterial connections, this morphologic right ventricle connects with this vessel, which, as you note, the head and neck vessels are located here, is an aorta, and is located anterior and to the left of the pulmonary trunk that comes from the morphologic left ventricle. So it is like in a normal heart, but instead of the pulmonary trunk being here, anterior and to the left, is the aorta. So this is an aorta left-sided and anterior with usual atrial arrangement. And it explains why the term DTGA is such a wrong term. And I would wonder, where would you put this heart in a study, in a surgical study, if you are talking about DTGA with an aorta that is left-sided and anterior? And then if I look on the surface of the interventricular septum, you notice this defect, which is in the outlet septum. It's between the limbs of the septomarginal trabeculations. Let me zoom in a little bit so we see the defect better. And as you see, the outlet septum, which is located here, this is the outlet septum, is slightly malaligned in the caudal position, posterior. And I'll show that from the left ventricular side. But we can also see that there is a muscular defect, outlet defect, embraced by the two limbs of the septomarginal trabecula. If I rotate the heart to look from the left ventricle, we can also see beautifully how this outlet septum that you see here, this one, is malaligned into this left ventricle and below the pulmonary trunk. Now, in terms of what happens between the mitral valve here and the pulmonary leaflet here, I would say that there is continuity, fibrous continuity between the pulmonary leaflets and the anterior mitral leaflet. So again, this is a nice case of anterior left-sided aorta. If I move to the next two specimens, we'll show the rare case of a so-called posterior transposition. again, I'm glad that this heart has the trachea, because otherwise, with only the heart specimen, it's very easy to rotate the heart as you like, and you think that the aorta can be almost anywhere. But in this case, let's look again. This is a morphologic right atrium on the right side of the septum, a morphologic left atrium on the left, usual atrial arrangement. The connection between the right atrium is made with this ventricle, which is a right ventricle, as you see the trabeculations. And from this right ventricle, the vessel that originates, I will zoom in a little bit more. You can already see the head and neck vessels here, but you can also see a coronary artery here. So this is an aorta that originates from the morphologic right ventricle. From the morphologic left ventricle, it is the pulmonary trunk, as you see here, with this is the left pulmonary artery. Now, if we look at how this heart sits, you will notice that this pulmonary trunk will be located here, is anterior, whereas the aorta is located slightly posterior and to the right. So the aorta will be located in its usual position. One element that I'd like in a normal heart, but not the usual position for a usual transposition, which would be anterior and to the right. So this is a heart with a posterior and right aorta, anterior and left pulmonary trunk. It's still a transposition because there is discordance at the level of the ventricular arterial connection. In terms of the coronaries, we have to remember that if we use the Leuven-Leiden classification, then the observer sinus will be located here because it's the furthermost away from the sinuses of the pulmonary trunk. So the sinus number 1 will be here, the sinus number 2 will be more posterior. And in terms of coronaries, from this sinus, as you see here, I'll try and zoom in a bit more. This coronary that goes off from the sinus number 1 will give us both the left interventricular artery, but also the right coronary artery. This is the right coronary artery that goes all the way into the right atrioventricular groove in front of the aorta. From the posterior sinus, or the second, sinus number 2, or the left-handed sinus, as you see here, because this is the observer sinus here. So this is the left-handed sinus, number 2. We have a coronary, and if I turn the heart to look at this coronary, you can see beautifully that this is a circumflex that goes behind the pulmonary trunk. This is the pulmonary trunk. This is the aorta, and this small coronary here, coming from sinus number 2, is the circumflex going behind the pulmonary trunk. So a case of posterior aorta. And the third specimen I wanted to show you, and I'm glad again because I have the pedicle of this heart. I'll zoom out a bit. So as you see here, the trachea and the esophagus, but let's end the lung and heart block. The heart is here. Again, morphologic right atrium on the right, morphologic left atrium is on the left here, usual atrial arrangement. The morphologic right atrium connects with the morphologic right ventricle, and the morphologic left atrium connects with the morphologic left ventricle, as you see here, the crisscross trabeculations. And if I look at this heart again, please note where are the great arteries. I'm holding the left lung here, right hand here. This is the pulmonary trunk. This is the aorta. You see here the head and neck vessels with the left arch, but the pulmonary trunk is located anterior and to the left to the aorta, which is posterior, and to the right. So you will remember that this is the position of the normal heart with the usual arrangement of the great vessels. But in this case, we are in a ventriculo-arterial disconnection type. And that means that we have a so-called posterior aorta, which is extremely rare. If I look at the interventricular septum from the right side, I'm here in the morphologic right ventricle, you immediately notice a defect in the outlet area. I'll zoom in so we look at it better. And what we have here is the aorta. You notice here the coronary, the leaflets, the tricuspid valve is down here. The defect is here in the limb, when it's embraced between the limbs of the septomarginal trabeculation, that is here. You see it's very close to the aortic leaflets. And yet, if I look behind, and I'll move now into the left ventricle, as you'll see, it's something interesting. Now, this is not the defect. This is just a ruptured part of the parietal structure. The defect is here. This is the mitral valve, the anterior mitral leaflet, as you see here. And this papillary muscle, the anterolateral papillary muscle, has a direct muscular connection that goes into the outlet septum. This is the outlet septum slightly deviated caudally just below the pulmonary trunk, as you see here. So this is the outlet septum. So there is discontinuity between the pulmonary leaflets and the anterior mitral leaflet. As you see, this is a muscular structure. Again, this is not the VSD. The VSD is here. And again, I show you two examples of posterior transposition, one with intact ventricular septum and one with muscular outlet VSD. Remember that this is important when we use the Leiden classification to position ourselves in the observer sinus, which is here. So this will be sinus number 1 here, and the sinus number 2 will be more posterior. I can only see one coronary in this specimen, which is located here in the left-handed sinus, because the observer sinus is here, the pulmonary trunk is here. So I'm in sinus number 2, and it's a single orifice that is quite high. As you see, this is the sinutubular junction, so it's quite high, and I couldn't find any other coronary orifice. It's probably a single coronary. We can discuss with Dr. Quintessenza the impact of having this posterior transposition has on the transfer of the coronary buttons. I wouldn't expect problems, but as you see, this is a single orifice coronary in this case. Thank you very much. I do hope that Sasha is now ready to take over.
Unfortunately, not yet. Thank you very much, Adrian. Beautiful models for sure. And we have one question so far. I think we can answer while Sasha tries to reconnect. If Dr. Anderson could answer, or yourself, Adrian, there's a question about what's the difference between de-looped and de-transposed?
Oh, I will leave this to Professor Anderson. I'm sure he will be delighted to answer it.
I mean, this is the problem with using de-transposition at all, because there is no certainty of what people mean by de-transposition. We discussed this last week. Dr. Van Praagh and people, when they use de-transposition, they think they are speaking Van Praagh, but they're not in fact speaking Van Praagh, because Van Praagh talks about transposition SDD or transposition SDL. So Dr. Van Praagh, in fact, didn't introduce the terms D-transposition and L-transposition. In many ways, it's a bastardization of Van Praaghian terminology to talk about D-transposition and L-transposition, because when you say D-transposition, do you mean the aorta is anterior and to the right? Do you mean there is D-loop transposition? But even if you mean there is D-loop transposition, in that case, transposition IDD is D-loop transposition and is congenitally corrected. So the bottom line is that we cannot use D-transposition as a synonym for the combination of concordant atrioventricular and discordant ventricular arterial connections. It is simply transposition. And if you wish to be Van Praaghian, then there's no reason why you shouldn't be. But in that case, the first heart that Adrian showed you is transposition SDL, cytosolitus D, bulboventricular loop, left-sided anterior aorta, transposition SDL. It is not D-transposition.
Bob, I wonder whether you or Adrian will talk about the high coronary in association that Adrian showed with the single coronary and the risk of this being an intramural coronary.
Well, I think that whenever you have a high origin of the coronary artery, there always is going to be some degree of intramurality, and that depends on how you define intramural. I mean, for a start, the coronary artery has to pass through the wall of the arterial valvar sinus in order to get out. So there's always going to be some degree of intramurality. Typically, when we use the term intramural, we mean that the coronary artery not only passes through the sinusal wall, it also passes between the arterial roots. And oftentimes, as you know well, it crosses a commissure. But if you have high origin of the coronary artery, then that introduces a degree of intramurality, and the higher the origin, the more you have an intramural course. Hugh, you want to say something about that?
No, I just was trying to get my audio and video up and running, but I completely agree that when the surgeon first opens the aorta, the location of the ostium is a real key as to if there's some abnormality regarding, intramural, or not. And so that's just a key maneuver that the surgeon needs to really do, is just be very precise on where those ostia are in relation to the commissures.
Now, in terms of imaging, and this is probably for Dr. Silverman and the other cardiologists here, Dr. McGee, it's not easy to discuss the relationship of the great arteries. I don't know what you recommend, for example, in echo or in CT, because you really have to go to the base of the heart and to look at the orifices, the ventricular arterial junctions. And then that's not enough. You need a reference point to understand the aorta being anterior to the right or anteroposterior. So it's not always easy, I think, even with the best imaging. What do you think?
Norman could speak to that. I mean, Norman,
Yeah.
it's not easy, is it always, to be sure of the relationship of the arterial trunks?
Well, I think cross-sectional short axis imaging gives you that relationship quite clearly. We've had that in our chapter and the discussion I've done, that you can go and look at this from transposition, is that normally you see the great vessels and you can see the relationship which is right and left and which is anterior and which is posterior. And I think just using simple language, it's very easy to see whether the vessels are either side by side or front back, and whether the aorta is anterior or posterior. In fact, I've matched the picture that you showed, Bob, of Ben Wilcox with a picture of L-position great vessels in simple transposition. So it's very easy to recognize this on cross-sectional echo imaging.
Which is another reason why we shouldn't be calling it detransposition.
Right. Never had that problem personally.
We still couldn't get Sasha, but we have another question, and I'm sorry guys for that. I think he lost his connection, but for sure he's trying to reconnect. So there's one question from Jason Tan. He's asking, is the position of the great arteries and ventricular arterial discordance determined by the amount length of subvalve infundibulum?
Well, that's one of the things that contributed to it. I don't think it is only that. I noticed that he is using ventricular arterial discordance. I would much rather he talked about discordant ventricular arterial connections than we are precise as to what we're talking about. I mean, it's interesting that in one of the hearts that Adrian showed you, the heart with intact septum, and correct me if I'm wrong, Adrian, but in that heart, there was a subaortic infundibulum, even though the aorta was posterior. And in that heart that you showed us, there was also mitral to pulmonary continuity.
Yeah,
So that shows us, I think, that it is not the infundibular morphology in itself is not what dictates the relationship of the arterial trunks. Was that not correct, Adrian?
Indeed, this is the heart with the posterior transposition intact ventricular septum. As you see, there is a nice infundibulum here separating the aortic leaflets from the tricuspid valve. If I turn the heart to look from the left ventricle, again, there is a nice infundibulum between the anterior mitral leaflet and the pulmonary leaflets.
Oh, I was wrong. There is bilateral infundibulum in that heart.
In this one, yes. In this
Sorry,
one,
I mistook that. So in that instance, it could well be that it's the presence of that infundibulum in the left ventricle that is lifting the pulmonary trunk in anterior position.
Sure. Adrian, could you just put that heart up again for one moment and
Yeah.
let's look at the left ventricular outflow tract,
sure.
because it looks like, I don't know whether this is true, but it looks like the mitral valve has a septal attachment.
Well, you know, here is the septum. And as you remember in transposition, the septum is flat. It's something that we see clearly. This is that area that always we discuss where exactly goes the mitral valve, where you can see mitral and tricuspid valve together in the 4-chamber view. And I think it's just in that area of the inferoseptal recess that we discussed a few sessions ago. It's just where it touches on that space that you can see the end of the mitral valve attaching between the septum and the posterior wall of the left ventricle. I wouldn't call this attachment being septal, because imagine if there is no infundibulum here, these leaflets would be in fibrous continuity. So, and you'll not define that as a septal attachment. I think
you could just pull on the tendinous cord that's free there.
Yeah.
It looks like there might be a cleft in that anterior leaflet. No, it's when you open it up, it looks fine. Sorry.
It's here where the posterior wall, the inferior wall of the left ventricle continues with the septum, and it's exactly here where the mitral valve ends his so-called attachment to the septum. I wouldn't call it septal, but
And I agree with Adrian, because you can see the inferoseptal papillary muscle is well away from the
Yes.
septal surface there.
Correct.
which is here.
But it's the point he made, there's no recess there that is separating there is no trigone even, because there's a subpulmonary infundibulum. It's a very unusual left ventricular outflow tract.
I'm just looking at the other heart with the ventricular septal defect, the posterior transposition, and it's here in terms of infundibulum. And indeed, if these are the leaflets, the pulmonary trunk leaflets, again, this is a rupture, is a tear in the septum, it's not the VSD. The VSD is here. Yeah. So if I open this left ventricle and I go further, you can see the VSD on the back, but there is a clear infundibulum between the pulmonary leaflets and the mitral leaflet. But there is also this muscular attachment of the papillary muscle here straight into the septum. I think this is an abnormal attachment, as you can see here. Yeah.
That Adrian, that heart is very interesting, because when you showed it to us, you said that the ventricular septal defect was muscular, but in fact, it's not really muscular, is it? Because there's fibrous continuity in its roof between the leaflets of the aortic valve and the mitral valve.
Let's look again. So the aortic valve and the mitral, because of the position, I didn't really want it to open the heart more, because I got this tear in the septum.
No,
So
I understand that, but go to the other side and show it. Look at it from the right ventricular aspect, because as you know, we've agreed we should analyze it from the right. And there in the roof of the defect, there is fibrous continuity there.
Yeah, this is the anterior mitral leaflet. Let me zoom even more if possible. This is the anterior mitral leaflet here. And yeah, this is the aortic leaflet. I think yes, we can say that it's continuity. So yes, I was wrong about the muscular defect. Yeah,
but there is I think a muscular rim separating the Is there also tricuspid to mitral continuity? I think there is, isn't there?
You see, tricuspid is here. What happens in this area, I wasn't able to visualize very well because I need to look also from the other side. It may be that there is fibrous continuity. I don't want to speculate too much. I would have liked to open the heart wider on the left side.
But I understand why you don't want to do that, because it's already ripped a little bit.
Yes. And again, even in this heart, the coronary that I've seen here, it's quite high. I will show it in its origin. You see? It's definitely in the sinotubular junction, the origin of the coronary. How are we doing with Sasha?
And I got the presentation. I'm downloading now. I think a couple of minutes is going to be on my computer, and then we can restart. Perfect. We have another question here, asking about what is that make the frequent subaortic stenosis that we see in TGA?
Now that's a very good question, because in fact, when we run the video, when you eventually get it, Diane is going to show you a very nice heart that has anterocephalad deviation of the outlet septum, and she makes the comparison to tetralogy of Fallot. And that is a very nice comparison to make, because as you know, in the normal heart, when you have anterocephalad deviation of the outlet septum, as we have discussed, that is the phenotypic feature of tetralogy when it's combined with the septoparietal trabeculations. And Diane's heart that she shows you in the video has the same thing in the setting of transposition, but because it is the aorta that is arising from the morphologically right ventricle, that anterocephalad deviation of the outlet septum is producing subaortic obstruction. And that is going along, in her case, with severe coarctation. It's a beautiful demonstration. So you'll see that when hopefully, eventually you get the video running.
For those, just to clarify about this operated heart, this is a master that has been done here. So if I look from the back of the heart, this is the Acron patch that was used to switch the atrial at the atrial level. That's why we have surgical signs on this heart. It's from 1972. So at that time, there was no arterial switch.
1972, that is an old one. Goodness me.
I was not even born.
72 is not that old, Bob.
By the way, Adrian, when you opened that up, it looked like had the sutures started to dehiss from the mustard, or is that, would you say that that was well done?
Well,
we used to look at the mustard procedures. Almost invariably, there was still atrial shunting occurring across the baffle.
Yeah, this is quite a rigid heart. I don't know whether you noticed how difficult for me was to open it, and I didn't have time. It took me 5 hours to find them. I was really against the clock to find them, so I didn't have time to leave them in water to make them more flexible. So I didn't look very well on the atrial side, and I'm always worried not to produce tears before we get to image. So if I can show it to you now, this, let me put again, this is the right ventricle, yeah? Here, with the tricuspid, here. And you can see the patch, it's here, yeah? This is the patch, this is the tricuspid valve. Yeah. So in theory, we should have the pulmonary venous return coming through this valve, yeah, through the tricuspid, and then here on the back, going towards the mitral, which is here, we should have the systemic venous return going in here. But I think when the heart was open, that clear separation was lost. I can see the patch fixed here into the left atrium, yeah? But then I can't follow it well. I can follow it here towards the tricuspid. But that's the pulmonary venous, because the pulmonary venous, it's here, it will be anterior to the patch. So I couldn't really make it well. And
Did he use silk sutures to suture the atrial baffle there? Is that what that black is
Yes,
there?
yes, because you see, this is the systemic, this is the superior caval vein.
Yeah.
With the right atrium seen from posterior, so you would expect this blood to go into the mitral valve here.
Just as an aside, I saw a 39-year-old man last week with transposition with a mustard. He goes to the gym 4 times a week and he's still in sinus rhythm. But I guess he's done extremely well.
That's is that one of Mr. Monroe's?
It was, yes.
Well, Jim was a wonderful surgeon, and he was a real artist within the heart. So I'm not surprised. He knew exactly what he was doing. He knew how to avoid the sinus node.
He did. He did.
Alan, was that patient transposition with intact ventricular septum?
It was indeed, yes. With VSD, they don't do so well. But
Yeah.
septum.
Yeah, that's, people have forgotten what a good operation the atrial switches are for transposition intact ventricular septum. They don't get that right bundle branch block. They don't have interference with the tricuspid valve. It's a very different disease with a mustard or a Senec. Yeah. And, I wonder sometimes with all these cases of abnormal coronary paths that Diane and Bob and Norman have shown, is the switch going to be a better long-term solution when they have an intact ventricular septum? And just a curiosity, something to ponder.
Mm-hmm.
I think Grace said that we are ready to see the movie.
Bravo.
Yes, guys, I'm so sorry. Sasha had an emergency outside the hostel and he lost connection, but I'm able to broadcast the video now. I think this is where we stopped. If it's not, please let me know.
Presentations. Adrian Crucian is going to join us again from Birmingham, and he's going to show us one of these very rare combinations with what we now call posterior transposition. But the interesting ones are those with left-sided aorta. So this is a beautiful picture of this setting. There is the aorta. We know it's the aorta as it's giving rise. Picture is taken in the operating room by my late lamented colleague, Benson Wilcox. There's no question, but in this heart, the aorta, which is arising from the morphologically right atrium, is left-sided relative to the pulmonary trunk. The ventricular mass is showing right-handed ventricular topology, and there was usual atrial arrangement. And last week, we discussed how Richard Van Praagh, if he came across this combination, would call it transposition SDL. Because when you are using Van Praaghian terminology, it is the first word which tells you what is going on. And we know that when we have transposition SDL, these combinations, we have concordant atrioventricular connections because they're segmental harmony, solitus with D ventricular loop. But despite that, the aortic root is left-sided. So when we describe this in Van Praaghian terminology, transposition, SDL, everything is straightforward. We can also have left-sided aortas in this setting. You'll note there that the morphologically right atrium is left-sided. So this is transposition with mirror-imaged atrial arrangement. Now, as we've already discussed, you have left-handed ventricular topology. There is the morphologically left appendage, which is right-sided. So we have mirror-imaged atrial arrangement. Concordant atrioventricular connections means there is left-handed ventricular topology. And in this setting, the aorta almost always is anterior and left-sided relative to the pulmonary trunk. So again, in Van Praaghian terminology, we have transposition ILL, inversus, segmental harmony with inversus is L, bulboventricular looping, and we anticipate the aorta is going to be left-sided. So this is L transposition, but it is not congenitally corrected. So D transposition is not a suitable name for describing the combination of concordant atrioventricular and discordant ventricular arterial connections. And I've told you my preference is simply to call this combination transposition. So what we also have to remember is that on occasions we can have a posterior aorta. And this is the heart that hopefully Adrian will be showing you live at the end of today's presentation. The aorta is posterior and to the right. The cut tells you it is arising from the morphologically right ventricle, so you know there are discordant ventricular arterial connections. So there's the other cut showing you the pulmonary trunk, which is spiraling relative to the aorta, is arising from the morphologically left ventricle, discordant ventricular arterial connections, concordant atrioventricular connections, transposition, despite the fact that the aorta is posterior to the right. Now, we must also remember that infundibular morphology can vary. You're going to see that when Diane demonstrates the hearts to you very shortly. So we expect that there will be a subpulmonary infundibulum, and we expect that in the morphologically left ventricle, we find fibrous continuity between the leaflets of the pulmonary and mitral valves. But you're going to see a heart in which there's subpulmonary infundibulum as well as a subaortic infundibulum. And when Adrian shows you the heart with posterior transposition, you're going to see that that aortic root arising from the morphologically right ventricle in posterior position has its leaflets in continuity with the mitral valve in the roof of a coexisting ventricular set defect. So these are the things we're going to be looking at. We're going to be concentrating on the associated malformations, but you're going to see a heart that is very similar to this. The left ventricle is giving rise to the pulmonary trunk. We have discordant ventricular arterial connections, and the presence of a muscular subpulmonary infundibulum does not alter the fact that the ventricular arterial connections are discordant. But what we are concentrating on today are the associated malformations. Now, an atrial septal defect is important in this setting, and in times gone by, the opening treatment was usually a balloon atrial septostomy. And even nowadays, many of you do balloon septostomies for transposition. But we're not going to be looking at the atrial septal defect. We're not going to be looking at patency of the arterial duct, although that is also an important associated malformation. What we are going to concentrate on are those lesions that produce so-called complex transposition. Perhaps the most important is the ventricular septal defect, so we're going to spend quite some time looking at that. But remember, we can have obstruction of the left ventricular outflow tract. We can have obstruction of the right ventricular outflow tract. Diane's going to show you a nice example of that, and that is associated with coarctation. You should remember that we can find juxtaposition of the atrial appendages. We're going to look at that, but we're going to finish off by looking at the arrangement of the coronary arteries. But to start, we're going to look at the ventricular septal defect. We're going to start off by looking at a heart that has muscular ventricular septal defect. And what Diane is going to show you is that these defects can open to the inlet, the apical part, or the outlet of the right ventricle. Probably the commonest defect, nonetheless, is the one that is perimembranous. And we're going to emphasize that in this setting, we can have malalignment of the muscular outlet septum. And you're going to see that that malalignment can be posterior. If there is posterior or dorsal malalignment, that produces some pulmonary obstruction. But we're also going to show you a heart where there is anterocephalad malalignment. And that is associated with coarctation, as the anterocephalad malalignment reduces the size of the right ventricular outflow tract. And we're going to show you a heart that has a doubly committed and juxtaarterial defect. So now Diane is going to show you several hearts that have this, perhaps the most important of the associated malformations, transposition, discordant ventricular arterial connections coexisting with ventricular septal defect.
This specimen with transposition has the aorta anterior and to the right of the pulmonary trunk, which has a pulmonary artery band in this case. I'd like to mention that with transposition, we can have the same constellation of ventricular septal defects as in those cases that have concordant atrioventricular and ventricular arterial connections. So we're going to start out with the muscular ventricular septal defects, and these defects can occur anywhere over the muscular septum. So in the inlet, the outlet, they can occur anteriorly, inferiorly, and at the apex. And oftentimes when they occur at the apex, they're quite large, or they can be multiple, or the so-called Swiss cheese type of defect. This specimen has a mid-septal muscular ventricular septal defect, and you can see that it's kind of hidden behind the distalmost portion of the septomarginal trabeculation. So a bit more difficult to see from the right. If we look at these from left, a bit better, have a more punched out border because of the smooth nature of the interventricular septum as it extends towards the outlet. So we can see that trabeculation from the right crossing the opening of the defect, and there are its complete muscular borders. So a mid-muscular ventricular septal defect. The next specimen I have sectioned in a long axis plane, the majority of the right atrium, right ventricle, and some of the ascending aorta. And you can see that the aorta is almost directly anterior and slightly leftward of the pulmonary trunk in this case. Here we have a muscular outlet ventricular septal defect, so that the defect lies between the limbs of the septomarginal trabeculation, which is here. There's the cephalic arm, and here is the caudal arm, so that the conduction axis will be protected when the surgeon repairs this defect from the right ventricle because of this posterior inferior muscular bar. This heart also has some hypoplasia of the muscular infundibulum in the subaortic region. Looking at this defect from the left, we can see that posterior inferior muscular bar running between the tricuspid and the mitral valves, and as well between the tricuspid and the pulmonary valve, which lies in the outlet of the left ventricle in this heart with transposition. So an outlet muscular ventricular septal defect. This specimen with transposition has the aorta anterior and to the left of the pulmonary trunk. The right ventricle has been windowed, and there is a tiny central perimembranous ventricular septal defect that's very difficult to see. I placed my probe in the defect from the left side, and it is just beneath the zone of apposition between the septal and anterior superior leaflets of the tricuspid valve. The septomarginal trabeculation and the supraventricular crest are normally related, so that here is the cephalic arm and the caudal arm with the medial papillary muscle and the supraventricular crest inserting between the limbs of the septomarginal trabeculation in normal fashion. The defect from the left side shows us that it is indeed tiny, and it is perimembranous. There is fibrous continuity between the tricuspid valve and the mitral valve. And in this specimen, there is a quite narrowed area of pulmonary to mitral fibrous continuity. You can see this large muscle bar partially imposing itself between the mitral valve and the pulmonary valve. So this is a very small perimembranous central ventricular septal defect. Here we see the aorta anterior and leftward of the pulmonary trunk. And as you'll note throughout our discussion, the arterial trunks can have many different relationships as they exit the ventricular mass. This specimen has a perimembranous ventricular septal defect that extends into of the right ventricle so that it lies between the limbs of the septomarginal trabeculation or the septal band. So here is the body of the septal band. There is its cephalic arm and the caudal arm, which gives rise to the medial papillary muscle. If I tilt the specimen to look at the posterior inferior border, you see that the caudal arm does not reach the inner heart curvature, and this allows for the tricuspid valve and the mitral valve to be in fibrous continuity along the posterior inferior border of the defect. I'd also like to mention that the septoparietal trabeculations also can cause some degree of subaortic stenosis in these cases if they are extremely hypertrophied. Looking at the defect from the left, here we see the fibrous continuity between the tricuspid and mitral valves along the posterior inferior border. Here's the fibrous continuity between the pulmonary valve and the mitral valve. And you can see this muscle bar interposing between the tricuspid and the pulmonary valve, so that this defect is perimembranous, even though we don't have fibrous continuity between the tricuspid valve and the arterial valve. But because we have fibrous continuity between the tricuspid and the mitral valve along that posterior inferior border. I have another perimembranous outlet ventricular septal defect that shows us an interesting variation. And here, if we look at the arterial trunks, the aorta is even more anterior and leftward of the pulmonary trunk than the last specimen. The perimembranous ventricular septal defect extends into the outlet so that it lies between the limbs of the septomarginal trabeculation, which is here. Here is our cephalic arm and the caudal arm. And this is the medial papillary muscle arising from the caudal arm. If we look at the posterior inferior border, here is the caudal arm, which does not reach the inner heart curvature. It almost does, but there is still an interruption. So here is our tricuspid valve. And this portion of fibrous tissue is actually a very large remnant of the membranous septum, or a membranous flap. So at the posterior inferior border, we have fibrous continuity between the tricuspid valve, the membranous flap, and the mitral valve within the left ventricle. So this is a perimembranous outlet ventricular septal defect. Looking at it from the left, here is that almost aneurysmal remnant of the membranous septum or the membranous flap. And we see fibrous continuity between the tricuspid valve, the membranous flap, and the mitral valve along the posterior inferior border of the defect. Again, there is a muscle bar that interposes between the tricuspid valve and the pulmonary valve, which arises from this left ventricle in this heart with transposition. This specimen has the aorta arising immediately anterior to the pulmonary trunk and has an outlet perimembranous ventricular septal defect. This ventricular septal defect is fairly large, and it lies between the limbs of the septomarginal trabeculation. So here is its body with the cephalic arm and the caudal arm with the medial papillary muscle arising from the caudal arm. The posterior inferior border of the defect has fibrous continuity between the tricuspid and the mitral valves. You'll also note that there is some degree of hypoplasia of the subaortic muscular infundibulum, and it is actually deviated posteriorly. So there is septal malalignment in this case. Here we see the left ventricular outflow tract. We're looking up the barrel of the outflow tract from the apex of the left ventricle. Here's the mitral valve, and you can see the stenotic left ventricular outflow tract. This is secondary to the posterior malalignment of the outlet septum, which is this muscular bar here, impinging on the subpulmonary region. The ventricular septal defects shows us that it's perimembranous with fibrous continuity between the tricuspid and the mitral valves. And you can see that that outlet septum impinges between or separates the tricuspid valve from the pulmonary valve. The mitral to pulmonary fibrous continuity is in this area. The pulmonary valve will often be stenotic when you have posterior malalignment. And in this case, there is a bicuspid pulmonary valve, so that this leaflet is bisected, and there is the second intact leaflet. I have another heart with septal malalignment, and it is quite interesting. I've removed the front of the right atrium, the right ventricle, and the aorta. So there is a so-called secundum type of atrial septal defect or coronary sinus, and the tricuspid valve. The aorta arises from a very stenotic subaortic muscular infundibulum, secondary to anterior deviation of the outlet septum. So this is much like we see in tetralogy of Fallot, but this specimen has transposition. There is a ventricular septal defect that lies within the outlet of the right ventricle, so between the limbs of the septomarginal trabeculation. There is also a papillary muscle that straddles and allows the tricuspid valve to straddle and override the septum. So the consequences of the anterior deviation of the outlet septum show us that we can end up with either an interrupted aortic arch, or as in this case, of severe coarctation and a segment of aortic arch hypoplasia. So here are the brachiocephalic arteries arising from the aortic arch with this hypoplastic segment between the left carotid and where the isthmus joins the descending aorta, opening up the pulmonary trunk. And the descending component of the aorta shows us this very large patent arterial duct. And you can see the extent of the arterial duct because of this pale endothelial lining and the fine wrinkled endothelium. If we look at where the aortic isthmus joins the descending aorta, this opening is quite tiny, and it lies within the ductal tissue. So once the duct closed, this opening would most likely have closed and caused a physiologic interruption of the aortic arch. So when we look at the left side of this heart with transposition, here we see that papillary muscle straddling the septum with the tricuspid valve straddling and overriding the interventricular septum. There is also a subpulmonary infundibulum on the left, separating the mitral valve from the pulmonary valve and completely supporting the pulmonary valve within the outlet of the left ventricle. This specimen with transposition shows the aorta arising directly anterior to the pulmonary trunk from the ventricular mass. We have one remaining type of ventricular septal defect to discuss, namely the doubly committed and juxta-arterial defect. These defects are outlet defects as they lie within the limbs of the septomarginal trabeculation. So here's the body of the septomarginal trabeculation with the cephalic arm and the caudal arm. The caudal arm does reach the inner heart curvature in this specimen, so that there is a muscular bar along the posterior inferior rim. These defects can extend to become perimembranous as well. At the roof of the defect, there is fibrous continuity between the aortic valve on the right and the pulmonary valve on the left. The left side of the defect shows us the muscular bar between the tricuspid valve and the mitral valve along the posterior inferior border, and as well the fibrous continuity between the pulmonary valve on the left and the aortic valve, as we saw on the right. There is the fibrous continuity between the mitral valve and the pulmonary valve within the left ventricular outflow tract.
So the next thing we need to look at is those lesions that are producing obstruction of the left ventricular outflow tract. And here, anything that obstructs the subaortic outflow tract, concordant ventricular arterial connections will obstruct the subpulmonary outflow tract with discordant ventricular arterial connections. And in many instances, the obstruction is found at valvar level. Perhaps the most significant from the surgical stance is deviation of the outlet septum, and now it is caudal or posterior deviation, because this sets the scene for the Rastelli procedure or the Rev procedure, nowadays for the Mikaido procedure. So we're going to show you an example of that posterocaudal deviation of the muscular outlet septum. When you have an intact ventricular septum, then septal bulge is often the major problem, and that can be made worse by a fibrous shelf. Diane's going to show you a nice example of an aneurysmal tissue tag. In this instance, it will be an aneurysm of the partially formed membranous septum, but you can also have aneurysmal tissue tags derived from the tricuspid valve that blow from the high pressure right ventricle and obstruct the subaortic, the subpulmonary outflow tract. And much more rarely, you can have abnormal tension apparatus. So now again, Diane is going to show you and illustrate to you these lesions that are producing obstruction of the left ventricular outflow tract in the setting of transposition.
You'll all remember this specimen when we were talking about the different types of ventricular septal defect. And what I need to point out in this left-sided view is here we have the pulmonary valve arising from the morphologically left ventricle, and this aneurysmal remnant of the membranous septum can prolapse into the subpulmonary outflow tract and cause some degree of stenosis. So there are often tissue tags that come from the tricuspid valve prolapsing through the defect, and also in this case, the remnant, the very large remnant of the membranous septum. So this could be one of the substrates for subpulmonary stenosis within the left ventricular outflow tract in hearts with transposition. So when we're listing some of these substrates that can cause pulmonary stenosis in hearts with transposition, we will note that having a complete subpulmonary muscular infundibulum will create some degree of stenosis, especially if there is ventricular hypertrophy. And as well, this tag of tricuspid valve tissue that straddles and overrides the ventricular septum can also cause some degree of stenosis. As well, we looked at the heart with posterior deviation of the outlet septum, and you can see that that septal malalignment is yet another substrate for subpulmonary stenosis, so that this muscular bar or the outlet septum gets pushed posteriorly, and there is our severe pulmonary stenosis. Because of the low flow across this already stenotic outlet of the left ventricle, you typically end up with pulmonary valvar stenosis. And in this case, the pulmonary valve is bicuspid. So there's one leaflet that's been bisected, and there is our second leaflet. So this muscular outlet septum is one of the causes of subpulmonary stenosis.
Now, I've mentioned that you can have unusual associated malformations, and we want to concentrate on one in particular. And this is juxtaposition of the atrial appendages. And we have juxtaposition of the atrial appendages when one of the atrial appendages, the one we're going to concentrate on, is the morphologically right atrial appendage, passes through the transverse sinus so that it comes to lie to the left of the arterial valvar pedicle. And what you're going to see as Diane demonstrates to you this heart that has left juxtaposition, remember it is the right atrial appendage that is juxtaposed to the left, is the effect that this juxtaposition has on the morphology of the right atrium. So now we're going to look at a very nice example showing you quite a rare malformation, but one that you always need to bear in mind, juxtaposition of the atrial appendages.
This specimen with transposition shows us the aorta exiting anterior and leftward of the pulmonary trunk. And there's also juxtaposition of the atrial appendages towards the left of the arterial pedicle. When the right appendage extends to the left, it is typically located in a more superior position to the left appendage. Sometimes a small pouch can be left in its usual position, as we see here, and there are pectinate muscles within this small pouch that remains to the right. The appendage gets pulled across the transverse sinus, so posterior to the arterial pedicles. Where my thumb is the pulmonary trunk, because this specimen has transposition. Often the terminal groove runs in a more horizontal position than its typical vertical position. The sinoatrial node can actually be in an abnormal or aberrant position when this occurs, and it will be closer to the atrioventricular junction than normal. So here we see the inferior cable vein entering the floor and the superior cable vein, the roof of this right atrium. The atrial septum is often deviated, and the opening to the juxtaposed portion of the right appendage is often in the position where you would anticipate the floor of the oval fossa to be. There is a large atrial septal defect in this particular case, with only a small rim of atrial septum just above the tricuspid valve. Here is our coronary sinus, and when I tug on it, you can see the eustachian valve just above it. The pulmonary veins drain normally into the left atrium, and the left atrial appendage is morphologically normal. It is tubular in nature with a narrow junction to the venous component. And when we look into the left atrium, there is the smooth vestibule and the narrow attachment of the appendage. There are a few pectinate muscles spilling out, but in general, the remainder of the vestibule is smooth. So there is that small, short segment of atrial septum that remains that separates the atrioventricular orifices into the mitral and tricuspid orifices. So the juxtaposed portion of right appendage is difficult to see into, but there are pectinate muscles within that portion that is pushed leftward of the arterial pedicle.
So to finish off, we're going to concentrate on looking at the coronary arteries. Because nowadays, as you know, for the surgeon, almost always, the surgeon will be undertaking the arterial switch procedure. And the key to the success of the arterial switch procedure is transposing those coronary arteries from the aortic root to what will become the new aortic root. Of course, in the native situation, that is the pulmonary route. So there is quite some variation in the arrangement of the coronary arteries. We discussed this last week, and we're going to elaborate upon that today. And we're going to emphasize the most important feature when you are describing the coronary arteries is to establish a sinusal origin of those arteries. We also need to take account of the way that the three major vessels, the right coronary artery, the anterior interventricular artery, circumflex artery, the way that those arteries pass round the arterial roots so as to take their origin from the arterial valvar sinuses. Particular importance to the surgeon is the presence of an intramural course. So we're going to look at the intramural course. You're also going to see, as Diane demonstrates to you, the hearts, the significance of the sinus node artery. We're going to see that in several of the hearts she's going to show you. And then we need to remember that there can be commissural mismatch, although we're not going to dwell on that. But of all these things, most important is to take note of the origin of the coronary arteries from the valvar sinuses of the aortic root. And to do that, we need to distinguish between those sinuses. So this is a picture of the base of the heart. You're looking down on it from above. So the right side of the heart is to your right hand, the left side is to your left hand. So there is the aorta. It's positioned anteriorly, it's marginally to the right of the pulmonary trunk. And there are the coronary arteries. Now, as is almost always the case, coronary arteries take their origin from the sinuses of the aortic roots that are adjacent to the pulmonary trunk. Very rarely you can find a coronary artery arising from the non-adjacent sinus, and that's why we call it the non-adjacent sinus, because obviously if a coronary artery is arising from this sinus, it's no longer a non-coronary sinus. So what we're going to emphasize again is that properly to describe the variations, we need to distinguish between those adjacent sinuses. And for better or worse, we do this by positioning ourselves in the stance of this surgical mannequin, and we stand in the non-adjacent sinus and we look towards the pulmonary trunk. Now, we discussed last week the problems that you as echocardiographers have in achieving this stance, but you have to do it this way because this is the way that the surgeons understand the arrangement of the coronary arteries. Because irrespective of the way the arterial roots are related relative to each other, one of the sinuses is going to be to the right hand of the surgeon, standing upright in the non-adjacent sinus and looking towards the pulmonary trunk. And that right-handed sinus is the one we call sinus number 1. And what you are going to see is that in over 2/3 of cases, this is the usual pattern for transposition. The right-handed sinus, number 1, gives rise to the main stem of the left coronary artery, that then bifurcates into the circumflex and anterior interventricular branches. It then follows that if there are 3 sinuses, you're standing in one, you're looking towards the pulmonary trunk, we've seen that one sinus is to the right hand, and we're going to call that number 1. The other sinus is going to be to our left hand, and that is going to give rise to the morphologically right coronary artery, and we call that left-handed sinus number 2. Now, if you have 2 sinuses that give rise to the coronary arteries, you have 3 coronary arteries, there are 8 potential patterns. And here you see those potential patterns. And in over 2/3 of cases, this is the usual arrangement of coronary arteries in transposition. Sinus number 1, the right-handed sinus, giving rise to the main stem of the left, which branches into the circumflex and anterior interventricular arteries. The left-handed sinus number 2 giving rise to the right coronary artery. But this is only the usual pattern. So what we have to do is to have a system for describing what's going on so that we can recognize all the abnormal patterns. As I say, there are 8 possibilities. This is the experience from Birmingham Children's Hospital. Adrian Cruciano, you're going to hear later on in today's presentation, very shortly, along with Nigel Drury, have analyzed their overall experience, and they've compared this with a meta-analysis. And here you see the specific the experience of Birmingham, and you'll note that over 2/3 of cases have that regular pattern. And of the potential 8 cases, 6 have been seen in the experience of Birmingham. And they reflect marriage of convenience. The coronary arteries arise from the sinuses to which they are most adjacent, and hardly ever do the coronary arteries cross one another in terms of their epicardial territory as they take origin from the coronary sinuses. But very rarely they can do so. And we called this the black swan, when we found a particular rare variant in the experience of the cardiac surgeons working in Łódź in Poland. And this is the work we published recently in the Journal of Cardiothoracic and Vascular Surgery. And this is the arrangement that was our black swan. Because if you look at the course of the circumflex artery, in this instance, it's passing in front of the aortic root, antero-aortic course, and it is crossing the territory of the anterior interventricular artery. What Diane is going to show you is that almost always, when the circumflex artery does arise from the left-handed sinus number 2, it passes behind the pulmonary trunk. And she's going to show you some.
This specimen with transposition had the perimembranous outlet ventricular septal defect that we saw earlier, and as well has a coronary artery abnormality. So the non-adjacent sinus will be in this area where I flipped the anterior wall of the aorta back, so farthest from the pulmonary trunk or non-adjacent. And so when I flip this anterior wall of the aorta back, we see the right-hand facing sinus with closest approximation to the pulmonary trunk, and the left-hand facing sinus relative to the pulmonary trunk. So that arising from the right-hand facing sinus, or sinus number 2, is the left coronary orifice, and that orifice gives rise to the anterior interventricular artery. So no other arteries branch from this left coronary orifice that arises from the right-hand facing sinus, or sinus number 1. Arising from the left-hand facing sinus, or sinus number 2, is our right coronary orifice, and it gives rise to a normal right coronary artery that extends into the right atrioventricular groove. If we look within the transverse sinus, or posterior to the arterial pedicle, we can see that the circumflex coronary artery arises as the first branch of the right coronary artery. So it extends within the transverse sinus over to take its usual position within the left atrioventricular groove. So the right coronary artery arises from the left-hand facing sinus, or sinus number 2, and gives rise to the circumflex coronary artery. The anterior interventricular coronary artery arises from the right-hand facing sinus, or sinus number 1. This specimen with transposition has a coronary artery anomaly, and it was the one we looked at with the muscular ventricular septal defect at mid-septum. So if we imagine that the aortic valvular sinus farthest from the pulmonary trunk is deep to my probe, when I open the aortic root, there is that leaflet just here, and the right-hand facing sinus is bisected in this case. From the right-hand facing sinus arises a coronary artery. This artery also has what would be a short intramural course as it turns anteriorly to cross in front of the arterial pedicle and extend to the right atrioventricular groove, so that this coronary artery arising from the right-hand facing sinus, or sinus number 1, is the right coronary artery. The coronary orifice arising from the left-hand facing sinus, or sinus number 2, is the left coronary orifice. If we look posterior to the pulmonary trunk, we see that left coronary artery arising from the aorta and branching into the anterior interventricular and the circumflex branch as it extends in the left atrioventricular groove. So this specimen has 2 coronary arteries, with the right coronary artery crossing in front of the arterial pedicle and arising from the right-hand facing sinus, or sinus number 1, while the left coronary orifice arises from the left-hand facing sinus, or sinus number 2. This specimen with transposition is the one that has the juxtaposed atrial appendages and the central perimembranous ventricular septal defect. There can also be other malformations that we see in these hearts, and some get quite complex. The coronary arteries in this case are abnormal in that there is a single coronary artery. So if we look into the aortic valve, this is the non-adjacent leaflet with respect to the pulmonary trunk, and there is no coronary artery arising from the right-hand facing sinus, or sinus number 1. The only coronary orifice that arises from the aortic root is to my left hand, or from the left-hand facing sinus, or sinus number 2. So that this single coronary orifice gives rise to the right coronary artery that extends in usual fashion within the right atrioventricular groove. There is a branch that encircles the aortic root anteriorly and extends around to divide into the anterior interventricular and the circumflex branch. The circumflex branch will then run beneath the juxtaposed appendages and within the left atrioventricular groove. So this specimen has a single coronary artery from the left-hand facing sinus, or sinus number 2, that gives rise to all 3 major branches of the coronary arteries.
So of these variations, the most important is for the surgeon at any rate, is the intramural variant. Because although it's rare for the arteries to cross in terms of the epicardial territory, they can cross between the arterial roots. And this is what we call that intramural variant. And you'll note that 1 in 20 patients seen in Birmingham have such intramural anatomy. And this is what we see in the intramural variant. At first sight, when we look at the epicardial course of the coronary arteries, it seems it's going to be a usual pattern. But then when we look inside sinus number 1, there is no arterial origin. Instead, all of the arteries arise from sinus number 2, the left-hand sinus. And in doing so, the left coronary artery passes between the arterial trunks and crosses the commissure. And this is the essence of the intramural variant. Having taken its intramural course, the left coronary artery branches normally. The right coronary artery is also arising from sinus number 2. So Diane now is going to show you this very important variant. This is just one of the intramural patterns, but it is perhaps the most common of those intramural variants. And this is what now Diane is going to show you.
This heart with transposition is cut on the short axis, and we're looking at it from the base. We can see that there's usual atrial arrangement, and the aorta is anterior to the pulmonary trunk, so that this would be the non-adjacent sinus, or that sinus farthest from the pulmonary trunk. Here we have the right-hand facing sinus and the left-hand facing sinus relative to the pulmonary trunk. In this specimen, both coronary orifices arose from the left-hand facing sinus, or sinus number 2. The right coronary orifice has been cut away, and we just see the artery in this area. And the left coronary orifice has been cut along its length as it exits this left-hand facing sinus and crosses a commissure, so that the left coronary artery has a short intramural course as it crosses that commissure. So you can see the aortic wall and that short intramural course that it takes before it divides into the anterior interventricular and the circumflex branches. So this heart with transposition has both coronary arteries arising from the left-hand facing sinus, or sinus number 2, with a short intramural course as the left coronary artery crosses the commissure between the left hand and the right hand facing sinuses.
So what I hope we've now shown you again is that the essence of transposition is discordant ventricular arterial connections combined with concordant atrioventricular connections. If I had my druthers, I'd simply call this transposition. What we've shown you today is the importance of taking note of those associated malformations. And of these, the most significant are a ventricular septal defect, obstruction of the left ventricular outflow tract. But remember, anything that can occur at some time will occur, and so you have to be ready for it. And in that respect, we've shown you a very nice example with juxtaposition of the atrial appendages. But then we should also remember that variations in our aortic relationships or infundibular morphology do not change basic diagnosis, because what we have been discussing is the combination of abnormal segmental connections, in this instance at the ventricular arterial level. So what we have been discussing is discordant ventricular arterial connections combined with concordant atrioventricular connections, transposition.
Very good presentation. Very, very good. Thank you, guys. It was amazing.
I butt in for a second because I've got to leave very soon. Is that okay?
Say again?
Just a couple of clinical points. One is that the association of juxtaposition of the right atrial appendage is important. You recognize this, obviously. If you try and do a septostomy in these kids, and obviously we're doing less septostomies than previously, it's extremely difficult, almost impossible to do a septostomy of juxtaposed atrial appendage. And secondly, just quickly on the issue of mustard procedure, that Magda Jacobs brought this back into discussion now. Wrote a paper in January last year of their results of a modified mustard procedure, which is very useful for late presentation of transposition as you get in the developing world. And secondly, the modification he has described to enhance the atrial contractility. I'm not sure if that works or not, but it's an interesting to show that these operations don't necessarily go away forever. Thanks.
I think the point you make about the juxtaposition and the balloon septostomy is a very important one, Alan, because when Diane opened her heart, you could see that where you expected the oval fossa to be, that was exactly where you saw the juxtaposed atrial appendage. You must have done this yourself and pushed the balloon into the juxtaposed atrial appendage.
Yeah. You think you're in the right place, but you're not.
That was much more a problem in the days where guidance was of a septostomy was only with X-ray, because you really couldn't, unless you were doing with a biplane technique, know whether you were passing your catheter anteriorly into the right atrial appendage, or whether you were going posteriorly through the deviated atrial septum into the appropriate place to do the Rashkin procedure. And I think that this is really the problem, and the point that Alan makes is so important, and that Diane showed so beautifully, is that the atrial septum is also pulled. What I usually do is I talk to people and say, this is the left atrial appendage and this is the right atrial appendage, rather the other way around. I'm looking at myself backwards. And if you put your hand behind there, you get the two atrial appendages left juxtaposition, but the scapula and the whole humerus, which is the atrial septum, is pulled up into the into a different position. And that's one of the problems. It's also echocardiographically very difficult to recognize the juxtaposition of the atrial appendages, because not only are they positioned on the same plane, but they lie above and below each other. And so in order to see this echocardiographically, you have to scan very carefully over the upper parts of the atrial septum, because one is superior, which is usually the right atrial appendage, and the other is inferiorly. And you can see this long connection from the right atrium behind the pulmonary root into the upper appendage very easily. The left atrial appendage is much more difficult because it's usually much smaller in this condition.
It was a lovely ballet that you did there, Norman. Your choreography was wonderful. You have.
That was great. We probably should also mention, when we see that left juxtaposition of the atrial appendage, the association of some hypoplasia of the tricuspid valve and right ventricle. That should be a marker to look very carefully for those things.
Very good. Thanks, Gil, for that. I have a number. Are you finished, Alan?
Alan's gone. He's apologized to everybody. He's disappeared.
So, I think that one of the things that there's so many hidden values to this discussion, but the people that tell you that the fundamental of double outlet is the position of a muscular discontinuity between the mitral and pulmonary roots, making this double outlet makes this morphological method so ridiculous, because there's clearly on the specimens that we saw today were muscular infundibular in a number of the patients, and yet the patients' connections were really, truly transposed. And I think that this points out this feature that I think if I'd had this information in a debate that I had several years ago, would have made the assessment of double outlet by the mitral pulmonary fibrous discontinuity completely ludicrous.
Well, I mean, the point you make there, Norman, is so important, and I hope that is something that that's now being dispelled. And over the next 2 weeks, as you know, we're going to be discussing double outlet. We will make that very point, the point you've just made. You cannot use bilateral infundibulums to diagnose double outlet, because, as you say, several of the hearts we have seen today, if you were using that criterion, you would have had to call them double outlet. And as you say, that's a nonsense.
And you also can see that in the normal heart in 3% of patients. So to my mind, it's ridiculous, but it's an ingrained issue. And I think we have to hammer these points home very carefully.
You're right. And just as we have to hammer home, we're calling it detransposition. I mean, Adrian was commenting on me. Adrian has been at the British surgeons meeting all this week. He can speak for himself. He's muted at the moment, but he made the point that however hard you try, people continue to talk about detransposition. And Adrian, do you want to make a comment on that?
Yeah, I'm more worried about how we read various research in the area, because if we use detransposition paper, if we read a paper like this and we eliminated all these clear transpositions with the left side of the aorta, then we are mixing apple, oranges, and more fruits. It's just not logical.
But we know, in fact, that when people say detransposition, they simply mean transposition.
Exactly.
So why can't we just do away with the D?
Yes.
And do away with the L? Let's do without D and L.
Right. Especially when it's inappropriately used.
Absolutely. Well, hopefully we have lots of people who are with us and are listening to us on the Congenital Heart Academy. And this is one of the beauties, that we can pass this message now, and hopefully the people who are listening to us will take it on board. But old habits die hard. We know that full well.
Maybe this is a good time to start talking about the coronary nomenclature system, which, as you know, Bob, I really struggle with. I don't know if we have time to do it, but it's very surgeon-centric, which is the only time I know in all the great descriptions of nomenclature and anatomy that you have shown that we call something on the patient's right the left and vice versa. I think we have to be so specific about the coronaries to the surgeons that it's one of the few times that trying to put things into a categorical system may actually be not helpful. And I strongly prefer that we say where the sinuses are that hold the coronaries. That could be the patient's left, the patient's anterior and right. It could be straight anterior, and then which coronaries arise from them. As opposed to 1 and 2 and the surgeon's right hand, which is on the patient's left side. What do you think about that?
I hear what you say, Gil, but the problem is if you then try, as the surgeons do and as Adrian and Nigel Drury have been doing, if you then try to make a meta-analysis, if you're trying to do that with the specific description of the sinuses, it's nigh on impossible to compare them together. And the one beauty of sinus number 1, sinus number 2, is that throughout the world now, all the surgeons know what that means. So at least you can make sense of what they are describing. I hear what you say, but to me, the beauty of the Leiden Convention is that it takes away the variable of arterial relationship. I mean, I hear what you say, but if you have side-by-side great arteries, then the arterial sinuses are then anterior and posterior. They're not
Correct.
right and left. So then
And
you have to go on.
So,
No,
Gil,
so I think they're separate, because when I'm talking with my surgeon, right, I'm describing exactly what you just said. Great vessels are nearly side by side. The sinus in the anterior sinus is slightly anterior and rightward. The sinus that's posterior is slightly posterior and leftward. The sinus that is anterior is the one that's carrying the left coronary artery, and the sinus that's posterior is carrying the right. Now, I say that when I'm talking to my surgeon.
And
Now,
that is
how we
perfect
actually
when
write
you're describing an individual patient, and I go along with that 100%. But when you have 100 patients and you're trying to work out whether the patterns are comparable or not comparable, you've got to know that that sinus, which is anterior when the vessels are side by side, is leftward when the aorta is to the right.
yeah.
Yep, two separate issues, right? Absolutely two separate issues. And just like there's one for research, it's going to be hard to get people not to use DTGA. They like what they're used to. And I'm one of those people that likes what I'm used to. So I'll continue to call the coronaries that way. But when we write the papers, and I'll turn it over to Alan, when we write the papers, we do need some way to lump rather than split.
Indeed. And that, to me, it's the lumping where for my taste, I can understand the right-handed, the left-handed sinus. I mean, we're not naming the things because that's the way the surgeons do it. We're doing it because that's the way worldwide surgeons understand what we're talking about. Diane, is Q still with us or has he gone away?
I think he had to exit at around 10.
He's
Right.
trying to figure out where his right hand is, where his right hand and his left hand is in the
He's trying
sinus.
to check it out. But Gil, I think I've also supported your point, but I'm convinced that in order to describe this, we really need to consider how we talk about these things. And it makes sense to me that the Leiden Convention, which you used, in fact, in your chapter in the Moss and Adams, which I used a number of times to check it because also of my difficulty with this condition, is a very reasonable way to understand exactly what's happening with the coronary arteries. And as an echocardiographer, we discussed this last week, is that the problem there is that the surgeons and the anatomists look at the heart from above downwards, but you as a clinician and an echocardiographer look at the heart from below upwards. So that right is left and left is right, which further confuses the whole issue.
But
And
you did your little ballet with your juxtaposed atrial appendages. When you can do stuff like that, you can do it just as much upside down and get yourself the right way.
Well,
into the
I'm not
aortic
denying it, Bob. I'm actually supporting your point of view. I think that one has to really reconsider how one's looking at the thing echocardiographically, and then it becomes a conformed issue that you can use echocardiography again to look at these issues, which I think you can see in the majority of patients.
Adrian is still with us. Adrian, you can give the surgical viewpoint.
I think that if the training is to take you from specimens or today 3D prints, and then you will have a very clear and easy way to understand what the surgeons, what we say, because you only learn a code and then you are independent by whatever you want to put the heart in your hands. You look from the front, from underneath, from wherever you want. So you just learn one code in the Leiden classification. If you want them to translate into an echo image, CT image, where the patient is orthogonal to you, it's upside down, you're looking from the base, it's not that intuitive. I think if we start with looking at the specimens and the 3D print, the surgical classification is actually very easy.
So I think for the viewers here and the people that are looking at this, looking at these coronaries and saying, why is this important? And I think it's important because of the surgical issues. And we haven't talked about that, because when the surgeon has to switch the coronary arteries and the things, for example, like a double loop pattern, the arteries come under tension if a routine is placed. And so I wanted to ask you how you use the Leiden Convention and how you modify the translocation of the coronary arteries, which is the fundamental of understanding why these occur. Can you discuss that? For example, when you see a coronary artery which is arising, which has all three, how do you locate that, and how do you prevent tension? And also, so when it's a single coronary from the other side, those are really the important issues.
Of course, the Leiden condition is just the beginning. It's incomplete from our point of view, because it only tells you about the sinuses, and it tells you about the facing sinuses, which is important, but it doesn't tell you about intramural, pericommissural, where exactly is in the height. It doesn't tell you where is the looping, because when our article, the meta-analysis that will actually build on the Sara Pasquali article, meta-analysis done in the beginning of 2000, you will see that it's not enough the Leiden. You have to discuss the looping, and then you have to add the intramurality or interarterial course. But I think it's a good beginning. It's a good tool to start with, because if you know that they start from the sinus, the facing sinus, and in one you have the left corner, you know that that will be easy to translocate. But if you have the left coronary from sinus 2 or any other combination where the coronary becomes far away from its ventricle, then when you translate it, when you harvest the button and translate it, it will be much more difficult. But Leiden is just the beginning.
But Adrian, that's what I try to emphasize as I present, that when we're discussing the coronary arteries, we start with the sinusal origin.
Yeah.
And that, as you say, that is all that you get from Leiden. And then on top of that, you have to give the additional information, the course relative to the arterial pedicles, the intramurality. But if we're going to describe the course from the sinuses, without question in my mind, the Leiden Convention is the best way of doing it because it accounts for all the patterns. And
Yeah,
I mean, as Gil knows, we found that amazing heart from Wodge, which is the only one we're aware with the crossing of the ventricular territories.
Mm-hmm. I wonder, what I really have great difficulty understanding is how, when the artery has a long intramural course, you can remove this coronary artery and translocate it. It would be wonderful if we had 3D printing and you could show us how you correct this, but it would be great if you could just describe how you make this trapdoor phenomenon.
Norman, the heart that I showed with the intramural coronary artery was actually one that a surgeon was using to practice on to move that coronary, because I put it back together, but there was a little rectangular or button of tissue removed in order to transfer that coronary, or practice transferring that coronary to the pulmonary trunk.
Would have been great to see that, actually, because I think that a number of us have a lot of difficulty understanding the surgical technique for doing it. We know that the surgeons can handle almost anything, but it would be wonderful to be able to see that heart put back together with a three-dimensional printing, which you can do by CT, and have the surgeon show us in the future how this can be translocated. So Diane, I have another point that I want to get into. With the session's very long, and I think it just bears out how important this long discussion is of these patients. But you showed us many examples of the ventricular septal defect cradled in the arms of the septomarginal trabeculation, which you called outlet defects. And there was also a deficiency of the posterior limb, so that brought the defect into a perimembranous position. How do we call these defects? Do we call them perimembranous, or do we call them a outlet VSD, or do we just call them an outlet VSD with perimembranous extension?
You pays your money and you takes your choice.
Yeah, well, but I'm looking at that because it's sometimes, you see both of the things. You see the fact that there is fibrous continuity between the mitral and tricuspid valves, and you say it's perimembranous. And I assume that the importance is to tell the surgeon that piece of information, but also that the defect is extending into the outlet septum, which creates a problem for the surgical repair of this defect, because he's going to have to look at that defect through the amputated arterial roots to actually do a repair in those particular, he or she is going to have to do a double approach to fixing that type of ventricular septal defect.
But both of those features are important. You then have to decide which you think is crucial. And again, we come back, you are the echocardiographer, you're making the diagnosis and you're presenting the information to the surgeon. And it is the borders that tell the surgeon where the conduction system is. And to me, that is the key surgical feature. So as you say, it's also important to know how it opens. So I would start off by saying it's perimembranous, because then the surgeon immediately knows that the conduction tissue is going to be at risk. And then it's a perimembranous defect that is central, or it's a perimembranous defect opening to the outlet, or a perimembranous defect opening to the inlet, or a perimembranous defect that is confluent. But I think you give all the information.
Let's just ask Adrian, as he's the surgeon in the group, do you inspect the ventricular septal defect through the transected aorta and pulmonary roots when you do a ventricular septal defect transposition repair?
Well, if we know that the defect is outlet, and then we understand that it's muscular, that's all it says. And then you have to look at the upper border from that defect all the way to the arterial leaflets. Sometimes you can start closing the defect through the atrium, and then for the upper sutures, you can do it through the arterial.
That's the point that I wanted to make about talking about that. So it's not a problem for you as a surgeon, because you're going to look at the ventricular septal defect both ways.
Exactly.
But the fact that as Bob said, is we tell you it's perimembranous, you know that you have to use suture placement on a different place, and perhaps use, as Diane had showed us, the membranous flap to place the sutures in as well.
Yeah. But that will depend on the length of the infundibulum, because if you tell me perimembranous outlet, I know already that I have to look at that outlet. Where is the distance between the top of the defect and the arterial leaflets?
Well, that's the point as an echocardiographer, because I'm always thinking of how I present the information to the surgeon, and I have to give him appropriate information. So it's very important to talk about these defects as maybe even as confluent defects, because they're going across two different borders.
Indeed. But I think all the information is important. It's what Gil says, when you're describing any individual patient, you have to give the full picture. But it's when we are trying to compare the results in the different ones, where then you need a system of categorizing the defects. And then again, you have to give all the information.
Right. Well, it's been an amazing session.
Is Grace still with us?
Yes, I'm here.
Very dense.
It was very intense session. It was really, really good.
Have we got any questions that are particularly burning that need to be answered?
I think we have more comments than questions, actually. And I think we've been more than 2 hours. I think we need to close up now, but it was amazing. It was really, really good.
And thanks to David for being with us. It's nice to see you there, David.
Thank you, David.
Thank you very much to all the panelists. It was amazing as usual. And thank you guys for attending today. We are sorry for the technical issues, but I'm sure we overcome that in a very good way. Adrian showed us very beautiful specimens while we were waiting. And hope to see you all soon. Next week, we're going to talk about double outlet ventricles with Dr. Anderson in the next couple of weeks. And we have on the 20th, Dr. Gill, and the 21st, Dr. Mary Cohen. See you soon, guys.
Thanks very much.